We are live now, doctor.
Yeah, thank you. So, very good evening, each and everyone. So, on behalf of the Executive Committee of Rajasthan Ophthalmological Society, I welcome you all. And this is the 33rd edition of the Kaksha classes for postgraduate teaching. And today we have Dr. Anagha Heroor. She is an MS, DOMS, FCPS, and DNB in ophthalmology. She is the medical director of Anil Eye Institute in Mumbai, and she is a member scientific committee of AIOS, president of Maharashtra Ophthalmological Society, executive member of IRSI. She's a member of FBS Women Empowerment Networking Committee. She has a lot of international presentations, including video presentations in Viscarus. She has performed live surgeries and at various platforms. She has won Best Surgical Video Award at ROS in November 2018, Best Surgical Skill Award in Women's Ophthalmological Society, Best Team in Scientific Presentations in WOS Bengaluru. She is a role model of the year she also has a role model of the year award in 2022 in WOS. Tejaswini Award 2022 by Rotary Club Dombivli, winner of West Bengal Surgical Video Challenge. And she also has a lot of awards like Bhagyashri Award, IRSI Gold Medal, Dombivli Bhushan Puraskar, Business Leader Award, I-Beach Film Festival Award, RJK Singh Community Ophthalmology Award to her accolades. So I welcome Dr. Anagha Heroor on behalf of ROS. And today we'll be talking about the small pupil. The small pupil is a commonly found issue with cataract, and with advancing age and many other issues, we can see these small pupil very commonly in diabetics, in people who are on prostate drugs, and many other things. So the topic will be the small pupil algorithm: when to stretch, when to hook, and when to ring. So we will have Dr. Sanjay Gupta has joined us as the moderator in the today's session. And we will have two residents, Dr. Anushka Gupta and Dr. Shivani on the hot seat. So they will be your prime interactors for this, Dr. Anagha. So welcome, Dr. Sanjay, and welcome, Dr. Anagha.
Thank you, Dr. Ankur Sinha, boss.
And over to you, Dr. Anagha.
I'm sorry for that.
No, that's okay. So over to you, Dr. Anagha. The webinar is all yours for about an hour. We'll have a masterclass in this. Thank you.
Shall I share my slides?
Yes, ma'am. Yes, ma'am.
Okay. Just let me know if it is seen.
It is not. Yes,
Yeah.
ma'am. It
Is
is
it-
visible now.
It's okay. Yeah.
Yes, ma'am.
Yeah. So at the outset, I would like to thank ROS as well as Dr. Ankur and your entire team for inviting me here. This is a really very good initiative, and I'm sure everybody who is going through these YouTube videos as well as these Kaksha classes must be really learning a lot from this. So I applaud this initiative. It's really very nice. So today the topic given to me is on small pupil: when to stretch, when to hook, when to ring. So basically, friends, when we are talking about small pupil, how small is really small? So is 2 millimeters small? Is 3 millimeters small? Is 4 millimeters small? Or there may be people who say, yes, 5 millimeter less and more is what I consider my threshold. So how do you define a small pupil? So basically, a small pupil is a relative term. It is a pupil size which is basically somebody who is comfortable depending on the surgeon's skill as well as experience, depending on the intraoperative situation, because suddenly the pupil can constrict on table as well, and depending on the iris tissue properties, like for example, in cases of IFIS. So what are the main and most common causes of small pupil? We have senile reasons. Diabetics many times have small pupils. Pseudoexfoliation syndrome, IFIS, if patients are on different kinds of drugs like tamsulosin, post-uveitis, synechiae, when patients have had recurrent episodes of iridocyclitis. Any patient who has had old ocular trauma or surgery, and now as a complication has developed synechiae and a small pupil, or patients who are on anti-glaucoma medication, especially with long-term myotics, or when there is already a trabeculectomy being done, and now the patient is having synechiae. So all these cases you have small pupil. So how do you manage these cases? First and foremost, you need to fine tune your surgery in various ways. Now, which are the ways? First is pre-operatively. So you need to plan, and you will only be able to plan properly if you have taken the proper medical history as to whether there is any history of taking drugs like tamsulosin, or even other drugs like for cardiac drugs, any ocular history of trauma or any surgery or any drops or long-term myotics that have been put. And make it a point to look at the pupillary size, not only in the undilated but also in the dilated position. So in the OPD, if you have already seen a patient where you know that the pupil size is 4 millimeters, automatically you need to start being mentally prepared. How you would be prepared on the day of surgery, what all things you would keep ready, as well as you need to explain to the patient that yes, your condition is slightly different from what it should ideally be, and that is why we will probably need some kind of special either OVDs or intracameral midriatics or special expansion devices like the hooks or the rings. So when you're already explaining to the patient, counseling the patient, they are also prepared. Sometimes these patients, you might decide to inject rather than doing it on topical. So even these things you can ideally tell the patient and explain to the patient. Then there are some techniques that you would probably plan to use, like pupillary stretching. Phaco settings. Now, what changes would you make? You would reduce the vacuum, you would reduce the flow rate, because especially in small pupils or in patients with IFIS, we know that there is a lot of billowing that occurs. And that is why you will also need to calibrate your side ports. So your side ports should be just tight enough that your instrument like your Sinski hook will enter. If it is very big, then there is more likelihood of fluid that is going to leak from these side ports, and this will cause shallowing of the anterior chamber and more chances of iris prolapse, especially in cases of IFIS. Then the materials you will need to keep ready is the OVDs as well as the pupillary expansion devices. Now, let's have a stepwise approach. Now, suppose you have a small pupil on the day of surgery. Obviously, you are going to call the pupil, call the patient in a dilated position. So, even after putting the drops, if there is adequate dilatation, obviously you will proceed with the surgery. If there is inadequate dilatation, either you see, yes, if there are no adhesions, you go ahead with the expansion device directly. If that pupil size is not comfortable for your surgery. If there are adhesions, then you will need to break those adhesions, probably need to do a little bit of stretching. Nowadays, a lot of people don't prefer to do stretching because it causes a lot of pigment release as well as inflammation. So they would probably directly go in for an expansion device after breaking the adhesions. You can also use intracameral midriatics, which we commonly see. So basically, they are a combination of phenylephrine, tropicamide, and lidocaine. Now, in spite of this, if it is not dilating, you can also use high molecular weight viscoelastics. So usually you will get slightly better dilatation with that, and then you can proceed with surgery. If still, if you feel that the size is small for your comfort, you can then use an expansion device and proceed with surgery. Now, a few months ago, I had sent out a practice pattern poll where we got around 510 responses from all over the country on which kind of pupillary expansion device is usually being used in small pupil phaco cases. So if you see here, you can see that around 24.5% of surgeons do not use any kind of pupillary expansion device. Okay, if you see 38.2% of surgeons use iris hooks and 19.6 use either the B hex or the B hex 2. So this is what is being right now the distribution in our country. Now, if you look at small pupil MS ICS cases, that is small incision cataract surgery, you will see that almost 48.3% do not routinely use. Now, what is the reason why such a large number of surgeons are not using pupillary expansion devices in SICS? Is number one, already in SICS, you have a very large incision. So there is less space for doing multiple incision for using iris hooks or using of a expansion ring like a B hex makes it little more difficult probably, and it doesn't give you so much of expansion. So in fact today the B octa, which is the newer kind of ring, is specifically made in fact for SICS surgeries. So all those of you who are doing routinely SICS and also have a case where there is a small pupil, you can use the B octa ring, so where you don't need to make multiple incisions, and you can also have a very good dilatation of the pupil. So we'll be speaking on this B octa ring in some more time. So 32.6% are still using iris hooks in SICS and only 7% are using the B hex or the B octa. So this we can discuss again later. So finally, in these small pupil cases, what is the requirement of using any kind of expansion device, and what is the advantage of having a bigger visibility? Because if you have a reduced visibility at every stage of your cataract surgery, there could be complications. Like for example, even when you're doing a rhexis, if you make a small rhexis, you will probably have difficulty getting out the nuclear fragments. You'll probably damage the pupillary edge with your phaco probe. You might take in the pupil edge or iris at multiple times, because once it comes into your phaco probe, then it becomes floppy, and this can happen again and again during surgery. Sometimes you may have some retained nuclear fragments, very small nuclear fragments beneath the iris. Especially if you're doing a toric lens, IOL placement becomes sometimes a little more difficult. So you'll need one more instrument like a V probably to, retract the pupillary edge so that you can place the lens perfectly and align it well. And if at all you end up having a PCR, then managing the PCR and visibility becomes all the more difficult. So all in all, you are likely to have a poor visual outcome and consequently an unhappy patient. Now, before you start managing these cases, you need to differentiate between an elastic pupil and a rigid pupil. So not all small pupils are the same. What is the difference between an elastic pupil and a rigid pupil, and how will you manage it differently? Now let's see. Now first is a rigid pupil. Now a rigid pupil is more, uh, you know, of you might see areas of sphincter atrophy, or the pupillary ruff is lost like this. Okay. Now, what about the elastic pupil? Now, many times, if you have put in a little bit of intracameral, you know, mydriatic or a visco, you can see how the pupil expands at least temporarily, and then it may come back. So the very fact that it expands temporarily means it's an elastic pupil. So here the pupillary ruff is intact. There is no area of sphincter atrophy, and it can actually dilate with visco. How much it will dilate, we cannot predict. Now, how will you manage them differently? Now, an eye face is a classic example of an elastic pupil. In these cases, you should avoid doing pupillary stretching in eye face, because the pupil is already floppy, the iris is already floppy, and by stretching the pupil, you will increase the floppiness and it can cause more progressive constriction. So in a case of eye face, if you feel that the pupil size is not as per your comfort, you can directly use a pupillary expander. Now, in case of a rigid or a fibrotic pupil, like for example in a pseudo-exfoliation, you can do a controlled pupillary stretching, and then if you feel that it is still not dilated well, you can go ahead and use a pupillary expander. Now, here is a case where there were some synechiae. So I'm first breaking the adhesions, breaking the synechiae, and you can use two V hooks and you can stretch the pupil in 90 degrees to each other. Once you do that, now you can see that the pupil has expanded to a level which is now comfortable for the surgeon. So you can go ahead and do your capsulorhexis and the hydrodissection procedures, the phacoemulsification, irrigation, aspiration, and put in a lens. So you can manage such cases as well. Now, if you are planning to use pupillary expansion devices, there are a huge list of different devices that are available today. Okay, the most common ones are the iris hooks, the B-hex ring or the B-octa, the Malugian ring, the Gupta ring, and so many other kinds of rings. So you can use whatever works best in your hands, whatever you're comfortable using, and whatever you feel is very accessible to you. Now, this is a case where it is a post chronic iridocyclitis patient where you have multiple synechiae and you have a festoon shaped pupil. So you can also see that corneal opacification in the periphery here. So the first thing you do here is you stain the anterior capsule with trypan blue and you break in all the adhesions and the synechiae very, very gently. Now you can see even after breaking the adhesions, the pupil is not dilated. So I'm doing a little bit of pupillary stretching. Now, in this case, we are doing a very gentle pupillary stretching because we don't want to tear the sphincters. Otherwise, you can actually cause a tear, irregular tear in the sphincters, which can cause a very irregular and a fixed dilated pupil in the postoperative period. Now you have already made the side ports for the irrigation aspiration bimanual, and now we have made the side ports for putting in the iris hooks. So usually we use around 4 iris hooks. So how do you put in these iris hooks? They are made of polypropylene. You can see the blue color and you can put them very gently from the side ports that you have made, and you have that uh, one white this thing where you actually tighten it. Okay, so once you tighten it, it stays in place. So you don't really need to pull the iris hook towards the limbus very aggressively, because again you can cause a tear in the sphincters. So you can be very gentle and then pull it only to the extent that you actually need for good visibility. So now that you have done, see here also we have not pulled it towards the limbus completely. So then you can move on, put in viscoelastic, fill the chamber and then continue with your capsulorhexis and the rest of the procedures. Now, once the rest of the procedures are done and your intraocular lens has been nicely implanted into the capsular bag, it's now time to remove the iris hooks. So when you're removing, first you have to stabilize the iris hooks and only then gently remove the plug and loosen it. So you can push the iris hook back into the chamber and you can either remove it at the same time or you can loosen all of the 4 iris hooks first and then remove them one by one. Both are fine. But do not just pull out the plug directly. You have to first stabilize with a McPherson the iris hook so that you don't pull on the pupillary edge. Once that is done, you rotate it laterally and then only gently remove it. If you just pull it directly, then it can cause again a damage to the side port or the wound. So you have to be really very gentle. During this time, you can have some amount of iris pigment dispersion, but if you are gentle, then the amount of iris pigment dispersion is really less. So now you can see we are removing the viscoelastic, and even though the pupil is slightly irregular, it's still not grotesquely irregular. Now let's see a patient where a patient is of a pseudo exfoliation. These are the two eyes of the same patient. But you can see in one eye, the pupil was dilated slightly better than in the other eye. So what we did was, in the eye which was slightly better dilated, we did not use iris hooks. And in the eye where it was slightly smaller, we used iris hooks. So the difference between the two is when you are using iris hooks, yes, the time taken is slightly more, but remember there's no ego in it. If you have a doubt that you might not be able to manage, please go ahead and use some kind of pupillary expansion device. Now, if you see the surgery on the left where I have not used iris hooks, you need to be very careful to be in the central 4 mm zone so as to avoid catching the pupillary edge or avoid damage to the PC, especially when you're doing an IA. So even though you will be able to manage with that kind of pupil, you need to be extra careful so that you don't end up having complications. Whereas if you feel that the surgery will not be optimally done without dilatation, you can please go ahead and use expanders. Now the difference here, you can see post-operatively, where we did not use iris hooks, the pupil is small and round. Here, because the iris retractor was pulled towards the limbus, you can develop sphincter damage like this and unsightly pupil shape. So you need to be careful. Now, another problem with iris hooks is where exactly to insert the iris hooks. Okay. So if you are very anterior, what happens here is you are tenting up the iris. So here you practically have a shallower anterior chamber. If it is too posterior, then you can cause bunching up of the iris at the anterior chamber angle. So ideally is not too anterior, not too posterior. You need to be exactly at the limbus and do not pull it towards the limbus completely. Now, is it safe always? Now here, just watch what is happening. I'm using these iris hooks and sometimes you have to be careful. The tip of the iris hook can be a little sharp. So here I've caused a tear in the anterior capsule during putting in the uh, iris hook. So here you have to be very careful about it. So sometimes you can push in a little bit of viscoelastic underneath the pupillary edge so as to easily be able to hook in. Now, whether it's iris hooks or in the B-hex B-octa, you can use this technique. So the disadvantages of using iris retractors are there you need multiple incisions, especially like for example, you have a post-trab patient. So already you have a bleb there, so you cannot put in your side ports there. Plus you have two side ports for your bimanual as well as a main incision. So the space becomes less. So in these cases, using iris retractors becomes a little more difficult. It's little more time consuming because you have to make so many incisions, put it and remove each one of them. And sometimes if you are retracting them unnecessarily more, you can cause finger damage. So let's go on to the rings that we use. Now this is the Melugin ring, which as you can see here is a ring which comes in two levels. Okay, there are the four scrolls that are there, and you can easily, it's a preloaded one. So when you inject it into the anterior chamber, you can put each scroll along the pupillary margin. Okay, now let's look at this case. This is a one-eyed patient where already a trap has been done. You can see that the trypan blue has already come into the bleb. Here we are using the Melugin ring. So you push in the Melugin ring from the main incision and then very gently, one by one, you need to align the scrolls along the pupillary edge. So you can use a Sinskey hook and you can align the scrolls along the pupillary edge from the nasal and the temporal side at the end. Once you are finished with your intraocular lens implantation, you can first detach each of these scrolls, and then either you can use the preloaded itself, the instrument itself, or you can use a Sinskey who can remove it. Now, the other kind of pupillary expander is the B-hex. Now, this was innovated by Dr. Suven Bhattacharya, our own Indian ophthalmologist, who is a great innovator, and he devised the B-hex pupillary expander. Now, why is it called B-hex? Is this because it gives you a hexagonal pupil, okay? And B is after his name. So the B-hex has 6 flanges. Okay, 3 of these flanges are without the hole, as you can see, which go above the iris, and 3 flanges are with the hole, they go behind the iris. You can use it vice versa also. And you have these 6 notches that help to engage the pupil. Now, there is also a newer addition to this family, and that is the B-hex2 and the B-octa. Now, let's see how they are different. Now, if you look at the B-hex and the B-octa, the B-hex, as you can see, is hexagonal. That's why it's called B-hex. The B-octa is called octa because it is octagonal. There are 8 sides to it. Now, these are the tabs where you can hold it. These are the notches, and it has these flanges which are much stronger than the B-hex. Okay, now let's see exactly how they are different. Now, this is the B-hex original one. If you see, the vertical diameter is 6.5 and it is 75 microns in thickness. If you look at the diagonal diameter, it is 6.75 millimeters. Now, if you look at the B-hex2 pupillary expander, the vertical diameter is 6.75 and it expands the pupil to 7 millimeters. And it is slightly thicker. So instead of 75 microns, it's now 125 microns. Now, if you look at the B-octa, which is the largest and the most recent in the B-hex B-octa family. Now, this has a vertical diameter of 8 millimeters. And the thickness is 125 microns. So it's firmer. So earlier when we used to have only the B-hex, then probably for rigid pupils, we preferred iris hooks or Malugan rings because they are stronger. But with the advent of the B-octa, we can use this as well as the B-hex2, which are thicker. So if you see, the first thing is in all these rings, I would recommend, and it is usually recommended to use it single use. Malugan ring, many people still clean and use it multiple times by doing ETO. And the B-hex and the B-octa, I would not recommend it all to reuse. So if you see the B-hex, it is the thinnest, softest. So it's best for elastic pupils. Now the B-hex2 you can use for rigid pupils, and the B-octa was made actually for SICS, but definitely you can use it for phaco. In fact, today for me, for all my small pupil cases, I have shifted completely to B-octa, and it is really a very valuable asset. It is the largest and people feel that it is most difficult, but you will see in some of the videos now that it's really not so difficult. In fact, it gives you better visibility and visualization. Now let's see how we use it. Now this is the B-hex. You can see that the pupil is small. I'm using a forceps. So it's a 23 gauge forceps by which you hold to the on the tab and then you put into through the main incision. Now, the 2 flanges on the side, you can use the side port. So you have to stabilize the globe well, hold the tabs with the 23 gauge forceps. You can use a Sinsky hook in your other hand and help to just gently release the flange underneath the iris. So you can see now you have a nicely dilated hexagonal shaped pupil. Now each of these steps can be done very easily. You saw how we did the capsular excess, the hydrodil dissection, the phaco. So it really doesn't hamper any of the steps of phacoemulsification. Now, once the IOL has been put, you can just gently hold on to the flange which is closest to the main incision and detach the other flanges as well. Hold on to it and then very gently through the main incision you can remove. In fact, it is so thin that you can also remove it through the side port incision. So it's a very thin, flexible kind of ring. You can see first day post-op, the pupil is nice and round and there has been absolutely no damage to the sphincter. Now this was a patient where it is a floppy iris and we are planning to put in a multifocal IOL. So we really do not want any damage to the sphincter. And you can see how the pupil came down more. Again here, the B-hex is being used. Use the 23 gauge forceps. So remember, always use these forceps which are specially designed for putting the rings. Do not use any other instrument because that will not give you the ideal or the best kind of outcome. So even in a case where you are planning to use a multifocal IOL, you can use the BX ring because it's very gentle on the pupillary edge. So you can see here the multifocal IOL goes in. You can see the rings shining and the BX ring can now easily be removed. You can see how the floppiness of the iris is still there. It's trying to prolapse. And this is the post-op day 1, 6, and 6. Nice round pupil without any damage. Now, this was another interesting case where we thought that the pupil size was good enough for me to go ahead with phaco. But even before we went in and did any kind of hydrodelineation or the hydrodissection, you saw how the pupil came down. Now, even after putting intracameral mydriatics, it did not dilate much at all. So we decided to put in the BX ring. Here you could also use iris hooks, but the iris hooks tend to pull onto the pupillary edge. So you might pull onto the capsulorhexis ridge as well. So you need to be very careful because that can tear the edge of the capsulorhexis. So that is why here we went ahead and used a BX, and you can see that the entire surgery was performed without any problem. But because of its uniplanar structure, sometimes there could be some challenges and there's a short learning curve. Now let's look at what are these challenges. So here I'm trying to just put in one flange underneath the iris. Now as we are trying to put in the third flange, you can see that the first one, the flange without the hole has also gone underneath. So sometimes you need to adjust it. Now here when I'm using the phaco, what is happening is because the flange is above the iris underneath the incision, sometimes very rarely this can happen, especially if the chamber is shallow. So it has dislodged the flange. So here we are putting in viscoelastic, putting in the flange again, aligning it, and then completing the surgery. This happens very rarely, once in a while. So what we modified was, so the flange which goes in the just below the incision, it's ideal to put it below the iris so that when you're putting in your phaco probe, it doesn't actually hamper the movement of the probe. So now see what we are doing. I'm stabilizing the globe and putting in the flange underneath the iris closest to the incision so that when we are going to use the phaco, it doesn't dislodge the ring. This helps to reduce any kind of dislodgement of the ring. So here you can see we are now doing the capsulorhexis, the hydrodissection. So the three flanges are on the other side apart from where exactly the phaco probe is coming. So you can very comfortably do your entire phaco emulsification without any issue. So here we are putting in the lens and then gently you can dislodge the flanges and then you can remove it. So there are various ways how you can remove it. Either you can dislodge each one, disentangle them and then remove it, or you can hold the one which is closest to the incision and remove it. See here again you can see there is absolutely no damage to the edge of the pupil. Now, this is another case where there are few more challenges and struggles. Now, let's see. Now, the problem with these rings are sometimes you can have more pigment dispersion. So, the first two rings have gone in. I'm now putting in, sometimes instead of the forceps, you can also use a Sinskey hook to use it to put in underneath put the flange underneath the iris. So if you feel it's not gone out, just remove the flange which has come from underneath the iris, put it back again, and then it goes on perfectly. So here you can see it's a multifocal toric IOL. So it really works beautifully. Now here it's a small pupil, mature cataract. In fact, it's a intumescent cataract and we are using a BHEX. Okay, so you have stained the pupil, stained the anterior capsule already with trypan blue. Now look at what we are doing. One of the flanges has now gone underneath the iris and we are not able to find it. So do not fish underneath the iris. So what you just need to do is the adjacent flange, just open it up back again, push in viscoelastic and then redo the entire thing. Okay, so very rarely you might need to do this. So you can see there is some amount of pigment dispersion, especially if it's a shallow chamber and a really small pupil. The third flange especially becomes a little more difficult. So remember to stabilize the globe at the limbus each time you are putting in the flange. And then at the end of surgery, you can easily dislodge the uh, flanges and then remove it. Now this is a pupillary membrane. Now let's see how we can manage this. It's a really small pupil. So here, first of all, we are breaking the adhesions completely. And I'm seeing if we are able to remove the membrane, but it's a membrane which is a very old one and it's really stuck. So we were not able to actually peel it off. But here, because the pupil is very small, it's such a small pupil, if you try and use a B-hex, then it will not go. So it should be ideally at least 4 millimeters before you use a B-hex ring. Now, this was at the time where we didn't have the B-octa. You can also use the B-octa for such cases, which gives you a better and a larger exposure. So here we put in the B-hex and we were able to manage the entire surgery well. And post-operatively also, the patient's visibility and the vision acuity was good. Now, can we do flax in case of small pupils? Suppose a patient is planned for flax. So, during flax, when you are putting in the femtosecond laser, if it's a small pupil, obviously you will create a very small capsulotomy. So, you can probably theoretically first go in, put in a BX or a Melugan ring, then take the patient back, do a flax, and then go ahead and do the phacoemulsification. But that requires taking the patient into the OT again and again. And if at all you plan to do a flax in a patient where you have put in viscoelastic or BSS, then you will have to optimize the settings and see that there are no air bubbles in it. Now, this was a patient where we had done a flax already. You can see the capsulotomy there. But then the pupil came down. So we needed to put in a pupillary expanding device even after the capsulotomy was done. So here we did that. So you have to be very careful not to engage any part of the flange of the ring in the capsulotomy edge. So you need to take care in such cases. Now let's look at the B octa. Now here you can see how the B octa is, you can see the dark brown color and the larger ring. So, okay, that is why people feel it's more difficult. So you have to just hold it at the bottom of the V, which is the holding tab. So the two flanges you can put from the right side port and two flanges from the left side port. So hold at the bottom of the V, pull it in towards the center and then release it. Sometimes you need to put the two edges of the flange by slightly pronating and supinating your wrist. So it becomes easier. Once the surgery is done, again like a BX, you can just disentangle the flanges and then remove it. This is a case where we have already done a flax. And now we are putting in the B octa. So now here, see, if we have put in the B octa and it's still engaging a part of the capsulotomy, you can see that the entire ring is irregularly placed. You can see how here it is irregularly placed. So you have to wait, go back, put it back, and until and unless you're sure that it has not engaged the capsulotomy, till then don't proceed with the next steps. So now once we did it two times, only then we were sure, and then we went ahead with the surgery. So once you are sure that the capsulotomy edge is free, then the entire procedure and the rest of the surgery becomes very easy. Otherwise, you can go ahead and damage the capsulotomy edge and cause a anterior capsular extension or tear. Now, the smaller the size of the pupil, it becomes a little more difficult. So here we are using the 23 gauge forceps. We have put in the two flanges of the B octa. Now I am putting the third one. Now as we are putting the third one, you can see if it's a small pupil, you need to actually retract and pull on the B octa that much more. Sometimes if it's a very thick carcass, like here, it's a very thick carcass, we cannot see where the edge of the flange is. So what you can do is you can use a Sinskey hook like this and push the other end of the ring so that this edge can be seen, and then you will be able to place it. Sometimes if it is more difficult, then you can use a slight pupillary stretching even after putting in two flanges of the B octa. So now this is another case where you are having a pupillary membrane. So try and remove the pupillary membrane first. So I'm just snipping it off. Again, very gentle stretching so as to be able to put in the ring. If it's very small, then putting in the ring becomes even more difficult. Now see, we are putting in viscoelastic. You can put in viscoelastic underneath the iris also to make space. Now we are putting in little more viscoelastic before going in for the third. This was a patient where the YAG PI has been done. Now see what is happening. If you are pulling too much, the entire uh, flange or the B octa can get distorted like this. So you need to be careful. So if it is getting distorted, that means you are pulling too much on it. So you just stretch the pupil a little bit with two Y hooks and you will be able to do it. Now, this was a case of an adherent leucoma. Now, you can see the adherent leucoma is covering almost half of the pupil. So, that much visibility is reduced. So, how do you proceed? So, what we did was we used a small micro scissors, and from the side port, we actually snipped off the adherent leucoma. So, freed up the pupillary edge along that. And now, in order to improve the visualization, now we are putting in the B octa. Now, see how we are putting in each flange of the B octa, and you will see at the end of it, you will get a nice big pupil and a very good visibility, because already the center visibility is affected because of the corneal opacity. So if we had not done this, then the lower entire half would have been really hidden, and probably it could have hampered the phacoemulsification, irrigation aspiration, and it could have created further complications. So that is why we decided to open up the pupil, and now with the B octa, we got really good visibility from all around the central opacity. So even though the center was not visible, the periphery was seen so well that we were able to complete the surgery without any problem or without any having a eventful case. So if you compare the Melugan ring with the BX or the B octa, what are the basic differences? Is you can put the BX even through the side port incision, not the B octa because that's thicker. The Melugan ring is made of 50 polypropylene, whereas this is black polyamide. The Melugan ring is biplanar, whereas the BX B octa are uniplanar, 75 microns and 125 microns for the BX and BX2 and the B octa. Melugan is manually made, whereas here it is a rapid machine production. Important is that the Melugan ring is a glued joint and it is biplanar, whereas the BX is a uniplanar and it is jointless. You need a 23 gauge forceps and it is more economical. Whereas in the Melugan ring, you can either use the injector system. Some people have also loaded on the Melugan ring on the routine butterfly injector that we use for our lenses, and you can use that as well. And it is definitely more expensive in the Indian scenarios. Ideally, all of these should not be reused, but because the Melugan is more expensive, there are people who use them again. Even the iris hooks, there are people who reuse them, but I personally do not. So to conclude, in today's world where there is more and more uses of premium lenses, like we saw trifocal lenses or trifocal toric lenses, and a case scenario where the patient also has a small pupil, patient's expectations are more and we want to give them the best possible post-operative visual outcomes. So you can optimally use these devices and help to overcome the challenges so that you can achieve not only the better surgical visualization during surgery, but also good visual outcomes and end up having happy patients. So thank you so much for your kind attention.
Thank you, Dr. Anagha ma'am. Thank you for such a wonderful presentation. All your videos were superb. Your videos of B Hacks Ring and B Octa Ring were superb. And I think this will help all our PGs and all the members who have joined in improving their understanding of managing the small pupil, and their fear of using all these devices will go off. So, excellent presentation.
Thank you.
I would like to add one
Yeah.
thing
Any
that
questions? Yeah, any
Any
questions, Dr.
questions?
Anushka or Dr. Shivani? Would you like to ask to Dr. Anagha? So I think everybody has understood it well. So videos were really nice, Dr. Naga, and I was watching all of them. It's a nice demonstration of all galaxy of cases, how the pupils have been stretched and kind of ringed and hooked. So that's really great. You wanted to add something, Dr. Sanjay?
I would like to add, I am not using B Hacks and B Octa, but I am using Gupta's ring since 6, 7 years. And it is also a cheaper one. It is a cheaper option. I think it is less than 2000 rupees. And it does not require any special instrument. Just with the help of Sinsky hook and your simple McPherson forceps, you can put it from 2.8 millimeter. And by Sinsky hook and Kuglen hook, you can easily entangle all the four hooks. And it also gives exposure of almost 6 millimeter. So, but definitely that B Octa gives you the biggest exposure of 7, 8 millimeter. That is the benefit of B Octa. But it requires some special instrument like forceps and
That once
experience.
you buy those forceps, then it is for life, no? So you can,
Yes, yes, yes.
that definitely you can only
It's
even
a
use it.
micro holding forceps now.
Yes, 23 gauge micro forceps. Yeah.
Micro.
Yeah.
But okay, that is a good option. B Octa is definitely good, as we all have seen from your videos. And regarding the iris hook, it sometimes lead to shallowing of the antechamber. Other than the inspector tear damage, that can happen to the capsule also, and even to the endothelium. This desmet membrane sometimes get detached when you try to directly pull these iris hooks. So it is better that all of us should learn these some kind of device which you think is better for you rather than the hooks.
But if you see the practice pattern poll that we saw, the
Mhm.
maximum number of people are still using iris hooks.
Actually, they started with the iris hook and now they are comfortable and
Yeah,
they
so
have
they are
some
in the
hesitation
comfort
in
zone.
using these Malugan ring and this all. So that
Actually, we are all trained with the iris hooks, to be very frank.
yes,
When
yes,
we were postgraduates and doing our cataract surgeries in the small pupils, probably that was the only device we had available with us. So
yes.
now with the advent of various types of rings, the things have actually become little easier than
The
what
biggest
we can think
advantage
of.
with the rings are that so many ports, 6, 7, 8 ports uh, नहीं बनाने हैं, तो leaky or shallowing of the antechamber, tightening, hydration, that will be a difficult problem with the iris hooks.
And if you're using premium lenses, like say, trifocal toric, for
You need
example.
a good shape after the surgery.
Yeah, so if you have distorted or if you have damaged the sphincter, then it becomes a little difficult. You can have glare, halos, so many other issues. So at least you
Yes.
should have multiple
Option.
Yes.
options so that whichever suits that patient at that point of time, I think you can use in whatever works best in your hands.
So there's a question here. Would like to ask, how do we manage such cases in government setup where we don't have all the instruments available? So that's a question from Dr. Akansha.
The iris hooks don't require any special instruments. You can use it with your McPherson. Iris hooks you don't require.
And iris hooks are not very expensive. It
They are
is a
not very
600,
expensive.
700 rupees affair only.
And I think the cost of even BHEX is also not very
It's not
much.
much. It's just barely 1500. I think same as
1500 to
Gupta.
2000, yeah.
Yes, yes.
So
It's
it's
not.
not very much, but the only thing is it may require some amount of holding forceps. So some type of holding forceps, whether it's the vitrectomy or a straight forceps or whatever you're
No,
comfortable
it
with.
is slightly curved at the tip.
Slightly curved, yeah.
Slightly.
Hmm.
But
Only
it's just a
expensive thing is
one-time buy,
Malugan
Yeah,
ring, which is more than 5,000. That is
which is
Malugan.
7,000 and more. Yes.
7,000.
yes.
Yeah, and even I've tried using it again, but I feel that the quality reduces and there could be chances if it's not cleaned properly, sometimes there could be some, viscoelastic attached to it. So,
And
do
in
you
government
reuse
setup, if
the
you don't
ring,
have
Gupta ring?
Hmm.
Do you
Gupta ring is
reuse?
good. I am using it since a long time.
No. Do you reuse it
No,
again?
I don't reuse it. I
Yeah,
just use one and then just throw it.
exactly.
It is
Yeah.
almost 1650 rupees off.
Correct.
That is
Yeah,
1500 plus tax.
reusing can also come with the problem of sticking of viscoelastic, which from the previous surgery, and then you can have a
Yeah.
task or something of that
Task.
sort.
Yes,
So it's
exactly.
better to kind of dispose
Better,
of.
yeah.
So the cheaper rings are that way, kind of a little better
Not really
option.
that expensive. So with
Exactly.
value gain, people try to cut costs and reuse.
And reuse it.
So I feel
Yes.
it is safer to use these things and with a cheaper and more affordable to our patients.
In
Yeah.
government setup, if you don't have any ring, any iris hook, then the only option is stretching of the pupil and then sphincterotomy. But post-operative problem of the glare and
Yeah.
many things will be
And
there.
post-op dilated.
Yeah.
So, ma'am, we can have a couple of questions for the quiz from your presentation.
Yeah. First question is, what is the composition of the intracameral midriatics?
So you'll have to type the answer in the chat box. The first two people who
Anushka,
type the answers will get the prizes.
Dr. Shivani, Dr.
Dr. Sanjay cannot type this
Oh,
time.
I won't type. What are the ingredients of the intracameral this injections?
Tropicacil and lidocaine.
No,
Shivani
No,
is there.
that's not correct.
that's not correct.
Not the correct answer.
Shivani is there, but we need a correct answer. If somebody can type it in next 10 seconds, we'll accept it, or this prize may be retained by the chairman scientific committee then. Phenylephrine and tropicamide. So
Phenylephrine.
that's also not
That is also not complete.
correct. So I think we move on to the second question.
Okay. No, it's not adrenaline.
No. So the correct answer would be, Dr. Anagha, can you tell the
Yeah,
kids?
it is phenylephrine, tropicamide, and lidocaine.
So now Anushka has written the answer.
Yeah. So
But
Anushka
it's
gets
on 8:23.
it's late. It's a little late.
It's a
So let's move on to the second question.
Okay. The second question is, what is the difference between B hex and B octa?
I repeat the question. What is the difference between B hex and B octa ring?
B hex 6 and B octagon.
That's
Hexagon and
all.
octagon.
Other differences also, no?
Flexible flanges, octa commonly used for SICS.
No,
So
but
now there are multiple things.
octa can be used
Size,
for
thickness,
also.
size, thickness.
So I think I can take the liberty to give the two prizes, one to Anushka and one to Shivani. Because these are the two girls who are answering the questions.
8 millimeter.
Even if they are, a little late or maybe half correct. So is that okay, Dr. Naga?
Yeah, of course, yes.
So thank you, Dr. Naga, for a nice masterclass on this non-dilating pupil or small pupil. And it has been really nice so that the kids could understand what type of problems they can face and various devices and how to use them. So thank you very much. And it was a nice lecture and a nice class. Thank you, Dr. Sanjay, for moderating the session.
Thank you, Dr. Ankur Sinha boss, for giving me this opportunity. And thank you all the participant, and a special thanks to today's teacher, Dr. Anagha ma'am, for excellent presentation.
Thank you, Dr. Ankur. Thank you, Dr.
Thank you, ma'am. Thank you. Yeah.
Thank you, ROS.
Thank you.
Thank you.